Hello, and welcome to the Surgical Assistant Podcast, a podcast crafted by surgical assistants for surgical assistants, where professionalism meets passion. I'm John.
Hi, I'm Kelly. Welcome back.
Hey, Kelly. So this is what's going to most likely be one of a three-part series in breast surgery. So I think this first one will be on breast surgery, diagnosis and treatment of breast cancer. The next one will be reconstruction of the breast cancer patient. And the third one will be on plastic surgery of the breast. I think that's what we're planning, right?
Yeah.
Excellent. So
We figured out pretty quick that there's a lot of material to cover here, and
there
we
is.
want to dive right in because this lines up with the goal of this podcast to bring information and viable and practical information to our listeners. So I'm really excited about that, John, and
Me too.
just covering these things specifically, and we each have something to share and something to bring to the table and learn from each other.
Mhm.
And we do want to let our listeners know that if there's anyone that listens to this and you have anything to add, anything to share that you might know that we all know that we can't know and see everything. We're
Mhm.
going to try to cover the big main points of what we're talking about. But please feel free to comment. We just want to definitely drive that home and encourage you to do that.
Exactly. This is meant to be comprehensive because we don't know it all. So we're constantly learning. So,
Yeah.
please feel free to leave in the comments anything that you think is pertinent, maybe something we left out or a correction or something that you do that we haven't seen. So, that's about fostering unity in the community, and that's what we're here for. So, why don't you kick it off,
Yeah.
Kelly?
Right. So if you're a new or young first assistant, you're going to find this very helpful. We're going to cover a lot of basics and we're going to cover a lot of specifics when it comes down to positioning the patient. So we're
Mhm.
going to start from the top. If you're a veteran first assistant, this will be a lot of review for you. And again, an opportunity for you to input and let us know. So, we're talking about the breast in surgery today, not covering plastic surgery. So, we're just going to cover some basic breast anatomy, the layers of the breast. Obviously, we have the skin from
Mhm.
the top. We have Cooper's ligaments. We're going to talk more about those in just a moment. Tipharus ducts, obviously in females, and adipose tissue. Then we have the blood supply of the breast. The blood supply is going to come from the internal thoracic artery. That's better known or more commonly known as internal mammary
Mhm.
artery, the intercostals, the lateral thoracic, and the thoracoacromial arteries are going to supply blood to the breast. Now, the venous drainage from the breast, the majority of the venous drainage is going to happen via the internal thoracic vein, the posterior intercostal veins, and the axillary vein. John, what is one of the interesting things we want to talk about in our venous drainage?
Did you mean Batson's plexus?
Yes, I'm talking about Batson's plexus.
It's
Tell us what that's about.
Batson's plexus is the valveless venous plexus that usually allows for a hematogenious spread of malignancies to the spine. So,
Right. Right. So that's just an important little nugget. You
mhm.
can impress your surgeon, or if you're working with a resident, you can impress them with your knowledge on Batson's plexus and what that is and why it is important to know about that. That is unfortunately the way that that blood can drain and cause that metastasis to the spine via the blood supply.
Mhm.
So let's see. Next, we're going to talk about innervation.
Mhm.
So let me just back up a second for maybe younger people. I'm going to try to break it down just a little bit. So these are all points of importance with no matter what area of the body you're working on, right, John?
Mhm.
It's important that we know our blood supply, our venous drainage, and our innervations for
Mhm.
whatever area of the body we're working on. So this is what we're covering here with the breasts. The innervation for the breast are both sensory and autonomic
Mhm.
nerves, and we've got several: the intercostal nerves, the lower cervical plexus, the supraclavicular nerves, lateral pectorals, medial pectorals,
Mhm.
long thoracic, and the thoracodorsal nerve. And we're going to talk a little bit more about those and why they're important in just a minute. here's what I want to talk about: the characteristics of breast tissue.
Mhm.
And we're going to go back to our layers and talk about the Cooper's ligaments. And if you're already a first assistant, you probably learned about this in school, in your school or your studies, that Cooper's ligaments are the connective tissue that basically run from the dermis of the skin, the deep dermis of the skin, down to the deep fascia of the breast. And this is actually what gives the breast its shape and firmness. So it's kind of what holding those puppies up, right? Over time, unfortunately, as we age, ladies, we do tend to lose our normal breast tissue, and it's essentially just left with adipose, a lot of adipose tissue there. Now, I did read, incidentally,
Mhm.
that push-ups, doing push-ups and certain types of rowing exercises
Mhm.
can actually help strengthen Cooper's ligaments. So,
Oh,
and improve the shape of the breast. So there you go.
there you go, ladies.
Well, I was going to say something about being in junior high school, and I must increase my bust, but I'm not going to go there. So, but that was legitimate information I read about
Mhm.
push-ups. So it made me want to go do some push-ups. But so that's the characteristic. So so seriously, along those lines, we do want to look at the
Mhm.
age of our patient that we're operating on. This is going to give us an idea of how that breast tissue is going to act during surgery. Okay, so if we're operating on an 80-year-old versus a 36-year-old,
Mhm.
we're going to be dealing with some different density in our breast tissue that can make surgery harder or easier. Again, also, when you're looking at our patient, we want to look at the size of their breasts. And we're going to get a little bit later down in this outline, we're going to get to why the size of the breast is important with our positioning and some things like that.
Mhm.
So, John, do you want to
Mhm.
talk about the anatomical borders in the axilla? Because we're going to move on to the axilla next. In addition to just the breast, we're dealing obviously a lot with the axillary region.
Mhm.
Part of the breast does include the axillary tail there that goes up into the axilla region. So
Mhm.
I'm going to let you talk about the anatomical and surgical borders of the axillary triangle there.
Okay. So when we're talking about axillary node dissections, your anatomical borders, superiorly, we have the axillary vein. That'll be the limit of our dissection superiorly. Then medially, we have the chest wall. Laterally is the skin. Anteriorly is the pectoralis major and minor. And posterior is the latissimus dorsi. So,
Okay. So, and I heard a surgeon say that you want to pretend like you're sitting
mhm.
in the axilla. If you want to imagine, shrink yourself down, you're sitting in the axilla and you're thinking of what's above you,
Mhm.
what's lateral, what's medial, your right and left, and what are you sitting on, to kind of think about those landmarks. So,
Yep, that's a good way to do it. I also saw a
yeah.
surgeon do that for the anus too, where he's talking about all the different layers. So I think I'd
Well,
much rather be in the axilla than the anus, though. That's for sure.
yeah, yeah,
And it'll
and those
probably smell a
muscles
lot
and
better. But
sphincters down there, we don't wanna, yeah.
yep.
So, yeah, but it's a good visual anyways to think of yourself sitting there. So you've got that
Hmm.
axillary vein. So when you're doing these cases and you're in the axilla, you can see, I mean, and if you're paying attention when you're assisting your surgeon,
Hmm.
he's identifying those structures. Whether he's
Yes.
saying it or not, he's identifying those structures, isn't he? He's looking and making sure where he
Exactly.
is.
And it's important for us because we're always a second pair of eyes. So especially when we do a sentinel lymph node biopsy in the axilla, or if we do an axillary node dissection, which is not as common anymore as it used to be. I remember when I was early on in the 90s, most breast surgeries included an axillary node dissection. And that can lead to some, pretty morbid complications. So that we don't do that much anymore. Breast surgery's changed so much. So,
It has changed so much,
um,
and yeah, it's changing every day,
mhm,
and we could have, yeah, and we
mhm,
probably will talk actually more about that in the part 2 of this, I would imagine,
mhm.
in our next episode on breast surgery, because things are changing and evolving literally month to month. As far as recommendations on, yeah, it's interesting field, definitely, to be working in. The lymph nodes that we're dealing with in the breast are significant because we are a lot of times looking for those sentinel nodes. And as we all know or should know, a sentinel node is the first lymph node that is going to drain from the primary tumor. that right? Yeah.
Yep, it's going to collect from the primary tumor because just think about a
Yes.
sentinel. A sentinel is a guard or a gatekeeper, and that's basically what it does. So I used to always get confused when I first started because I was thinking, which node is the sentinel lymph node? Like it was a specific one out of all of the lymph nodes, but it's not. It's the one that it's just called
It
a
happens to
sentinel
be
lymph
it happens
node,
mhm.
you know,
It happens to get that drainage first
after you
from
study
the
it, right, when you find the one
mhm.
that lights up the most, if you're using, radioisotope to find it, then that's the one that's got the highest
Correct.
count. That is the sentinel lymph node because that is the one that captured it first. So, yeah.
And that's interesting point, John, that you explained because I do find that a lot of I don't say a lot, but I have met first assistants as well as scrub techs and nurses that don't know that. They don't know that. And so we need to arm
True.
ourselves with this knowledge and understanding of what we're doing and why we're doing it with the surgeon, kind of knowing those things that the surgeon knows.
Mhm.
We're going to see in a few minutes why that knowledge is important because if you know what you're doing and why you're doing it, you're going to know what you need. Okay. There's I don't want to be, I don't want to sound too harsh, but it catches me by surprise sometimes. I'll just say it nicely when we're doing a simple, maybe we're on the books for just a simple lumpectomy.
Mhm.
Okay. And we're not involving the lymph nodes. We're not doing, for whatever reason, it is specifically, we're not doing a sentinel node. We're not going into axilla at all. It's just a
Mhm.
straightforward lumpectomy. And I've got the circulator asking me, do we need the ultrasound? Do we need, which I guess you might need the ultrasound for that, but they're asking me, do you
Mhm.
need the blue, the methylene blue?
Mhm.
And I have to say no. I mean, let's think about what we're doing.
Mhm.
Doing a straightforward lumpectomy. We don't need that. In their defense, they're asking good questions. I mean, at least they're thinking about it.
Sure.
But my point is knowing what we're doing, why we're doing it, what that sentinel lymph node is, what the
Mhm.
significance of that is just going to help us know what we need for the surgery and what we're doing for this patient. So I'm glad you
Right.
brought that up. Okay, so the lymph nodes in the axilla, there are actually 3 levels.
Mhm.
What is the significance of the levels of the lymph nodes, John?
Well, when it comes to axillary node dissections, the nodes that you take and the levels that you take are dependent on what you're doing the surgery for. So, for instance, if you're doing the surgery for breast cancer, we tend to just take levels 1 and 2. But if it's for a melanoma, then we'll take levels 1, 2, and 3. And,
Right,
the levels of the axillary lymph nodes are level 1 is lateral to the pec minor, level 2 is posterior to the pec minor, and level 3 is medial to the pec minor. So, although we don't do
right.
level 3 that often because it can be morbid as well. So, those
So
are
that would
only
be
a
if we're talking about yeah.
necessity.
So if we're talking about medial to the pec minor, you're kinda
Mhm.
going deeper in there from the outside. Wouldn't that be right?
Correct,
If you're
yes.
in the
Yep,
axilla, yeah.
medial to the right, and
You're really going down
there's
in
a
there.
node, in fact, it has a specific name between the pec major and the pec minor that's medial to the pec minor. Do you know the name of that lymph
I don't
node?
know it.
It's called Rotter's node. So,
Rotters, I've
it's
heard of
deep
it.
in there,
I
yeah.
haven't
In fact, I took it
I
the other
have
day
not
on a case. A patient, unfortunately, had many positive nodes. Well, many nodes that lit up with the technetium-99 isotope that we were using, and unfortunately, we just kept getting deeper and deeper, and we ended up getting in there pretty far and actually took Rotter's node, and unfortunately, they grossly felt diseased, which is,
Mm,
unfortunately not good for the patient, but breast
right,
cancer surgery and treatment has come so far than it used to be. I mean, with immunotherapies now and all the identification they have, patients can do much, much better. So,
right, right. So Rotters node, that does sound familiar to me. I haven't
mm.
identified that in a long time.
And I think if I read correctly, if we early with early detection of breast cancer nowadays, I mean, the success rate and the treatment rate is above 90%. I think it's above
Mhm,
98%. So, I mean, it's
mhm,
come a long way from what it used to be, which we'll talk about in a little bit. But,
right.
um,
And we know just while I'm thinking about it, the
mhm.
most common place for a malignancy to be found in the breast, location-wise, is the upper outer quadrant. I remember that being a test question on the CSFA exam, so if anyone's getting ready to take that, know that know
Oh,
that
there you
tidbit,
go.
but upper outer quadrant is the most common location in the breast for a malignancy to be found, so
Oh, very
I
nice.
really don't know the reason for that, but it is upper outer quadrant.
Okay.
So good deal. So we know if there's yeah, so if you're ever dealing incidentally, as a little side note, if you're ever dealing with a melanoma
Hmm.
that someone has especially on their arm, because the arm is a common place for skin cancers, melanomas in particular. So I'm not going to go into skin cancer melanoma. That can be another
Hmm.
episode.
Oh,
But
sure.
when melanomas are specific depth, right, they have to
Hmm.
have that wide surgical excision, local excision, and they're going to test that lymph node. They're going to test those axillary lymph nodes to see if any of that melanoma has spread, because obviously that's a very serious cancer to have.
Hmm.
So in that case, we would take all 3 levels of lymph nodes. That's what you're saying, right? That's what
Exactly.
we said. Okay. All right.
Exactly.
But no reason to take that level 3 in just breast cancer alone.
Correct.
I don't
And then
think.
that brings
Okay.
into another something we want to keep in mind. That is, if we're doing an axillary node dissection, then the nerves we want to keep an eye out for, especially the big 2 that we want to keep an eye out for in an
Mhm.
axillary lymph node dissection that have some pretty morbid consequences. So
Mhm.
um, the first one.
Yep. Yep. So we've talked about a lot of our landmarks here. We've talked
Mhm.
about our surgical borders, anatomical borders we're looking at. So those are our landmarks. And now we're going to, I'm all about verbiage, John. So we're going to talk about our landmines now.
Oh, there
Our
you go. I like
landmarks
that.
to watch out
Landmarks and
for. Yeah.
landmines. That's good.
So yeah, these nerves that can be injured during an axillary
Hmm.
dissection are important to know. And we've mentioned them up above. But the first one I'm going to let you go ahead and talk about.
Well, the first one I always look out for is the long thoracic,
Hmm.
and that innervates the serratus anterior muscle. And if it's injured, you can get what's called a winged scapula. So
Which means that scapula just kind of falls. No, it
it
kind of falls.
pops
There's a
out.
pic. Maybe you can get a picture of it and put it up on the screen.
Yes, I'll do that.
We
I'll
can
put
see
a
that.
picture
Yeah,
of
that's
complications.
yeah, it just kind of falls. It looks like the scapula's
Hmm.
kind of fallen away from you. So
Hmm.
we don't want to do that.
Do you want to talk
The
about what we
next
need to
one,
keep an eye out
yeah,
for?
is that I pronounce it thoracodorsal. I don't know how, our pronunciations are a little bit different, but
Oh, that's okay. I
this
see.
thoracodorsal, and it's easy to remember, guys, if you
Hmm.
want a little tidbit, it innervates the latissimus dorsi.
There
That's
you
how I
go.
always remember that one. It's got dorsal and dorsi. And injuring this nerve will cause weakness in your pull up motion. So it's going to be, right
Hmm.
there in your pectorals. And, just think of the muscles you're using when you're doing a pull up.
Hmm.
It's going to give you weakness there. I would imagine that it depends on the extent of damage that's done to these nerves. I'm always thinking when we're identifying nerves in
Hmm.
surgery, I'm always thinking, stay away, don't touch it if you don't need to, don't
True.
pull on it, don't manipulate it at all if you don't need to. And I would think that the extent of irritation that happens to these nerves is going to depend on to what extent these result of the injury would be. But
Hmm.
our point here is we want to know where they are, what can happen if we injure them, and to stay away from them.
Exactly. I know that.
There's one that's the most commonly injured nerves is what,
Which is the most
John?
common injured nerve in an axillary node dissection is the
Mhm,
intercostal brachial, and that leads to like
mhm.
numbness in the medial arm on the inner aspect of the arm. So, but I just want to go back to the thoracodorsal nerve and the long thoracic too as well, because with the origin of the thoracodorsal nerve is the C6 to 8 nerve root off of the brachial plexus, and it provides
Right.
motor innervation to the latissimus dorsi, like you said. And one thing I see, and you'll see constantly when surgeons are doing their axillary node dissection or their biopsy, they'll pinch the tissue before they cut it, because we want to
Mhm.
stimulate. That'll cause a depolarization of the nerve fibers, and it'll trigger the nerve, which is, and this brings up a very important point. Anytime we're doing a sentinel lymph node biopsy or an axillary node dissection, you want to make sure that anesthesia does not give any muscle relaxant at all, save
Very
for
good point.
maybe
Yep.
succinylcholine if they need it for the initial intubation, but make sure they use no long acting
Right.
muscle relaxers, because that'll block the function of that nerve, and we need to see that. If they pinch the tissue before they cut it, you'll see the latissimus dorsi flex. Same thing with the long thoracic. You'll see the
Yep.
the serratus anterior muscle fire as well. So, and it's pretty
Very good
significant when
point.
it
Yep.
does fire. I
Mhm.
mean, you'll see it. I
Yes.
mean, you'll definitely
Yep.
know, because the patient will move, and that's very important. That I always check with
Yep.
anesthesia when we start getting involved. I'll look over if the surgeon hasn't already asked and say, "Have you used any muscle relaxant?" Or if the
Yeah.
patient, yeah.
Thanks for saying that, John.
Mhm,
That's a huge tip, and a lot of times, of course, I've heard surgeons ask. Of course, the surgeon's gonna ask, but if
mhm.
you can get the jump on the surgeon, just as a little tip, as a first assistant, if you can be on your toes enough
Oh, yeah.
to ask or verify that with anesthesia even before the surgeon does,
Mhm.
guys, that just really helps your surgeon have that. You're jumping into that next level of confidence from your surgeon there. And that's a very good point you brought up,
'Cause sometimes they
John.
don't
Thank
remember. They may not be thinking to ask it because,
Mhm.
they're thinking about the next thing, or they're looking out for it, and they're just not thinking
Well,
about it.
right, and let's just back up to
Mhm,
before when you're readying the room. After the patient goes to sleep, you can put that little reminder in anesthesia's ear before the surgeon's even in the room, say,
mhm.
"Now,
Yep.
we're not gonna give any long-term, long-acting." Oh my gosh, what am I trying to say?
Any long-acting muscle relaxant?
Long-acting muscle relax. Oh my
Mhm,
gosh, yeah. So, yeah, I mean, you can kinda get the jump on it
mhm.
there, and, that's a really, really good point. I'm glad you brought that up. Thank you so much.
Oh, you're welcome.
So, talking about the nerves, that's what reminded you there. So, yeah, we talked about the most commonly injured, which results in some sensory deficit to that medial arm. I
Mhm.
think that typically resolves over some time,
Yeah, it can, but
unless I
sometimes
guess unless
they
it's
might end up with a little
symptoms.
patch that doesn't,
Right,
have any
right.
innervation. I had a shoulder operation, oh god, over 10 years ago now, and there's still a little patch in my arm that's numb. So, it used to be more of it, but some of it's come back. Not that this is I'm not equating the 2 surgeries, but,
Right.
some sensory nerve function can come back over time, so.
Yeah. Yeah. All right. So I know I see here that we wrote in the outline that the medial
Mhm.
pectoral nerve innervates the pectoral major and minor,
Yep.
whereas the lateral pectoral nerve
It's pec
does
major only.
the pec major only. So I think I just put
Correct.
those in there as little pearls that we need to
Mhm.
know. So medial pectoral
Yeah, well,
innervates
that's
both major and minor. Lateral is the major only.
right. Yeah, you mentioned those when you did your, sensory and autonomic when you listed the
Mhm.
nerves. Yeah, those are important
Mhm.
important nerves to know. So.
So let's move on to some common benign conditions of the breast. Now, most of the time,
Mhm.
we're not going to be in surgery for these, although I do have a little story about
Mhm.
something that's kind of related to this. The most common benign conditions we know, especially women in their 30s, fibrocystic disease is
Mhm.
a condition and cause fibroadenomas in the breast. So
Mm.
these are just little fibrous tumors that are completely benign, not associated with any malignancy or pre-malignancy. There are just normal breast cysts. And then mastitis is a benign condition. And
Mhm.
mastitis occurs when in a lactating mother,
Mhm.
typically where an infection happens. Now, in the recent past in my career, and I would say recently, I would say within the last year or so,
Mhm.
and I've worked in different facilities, so we're not going to identify any. We do want to put
Mm.
a little side note in here that we don't give any identifying information.
Mm.
I will say this has been recently in my career at one of the many facilities I've worked in different states.
Mhm.
So just throw that out there. We did have a
Mhm.
young woman that happened to be postpartum and she was lactating. She was breastfeeding her child
Mhm.
and she comes in with what appears to be she comes into the surgery department. So obviously she's been worked up and seen about it outside of surgery,
Mhm.
but it looks like a mastitis. It looks like a bad mastitis.
Mm.
And unfortunately, it
Inflammatory.
was a breast cancer.
Was
I
it
don't know that
inflammatory breast
I don't know.
cancer?
I want to say that it was inflammatory. It certainly
Mm.
was clinically significant for inflammatory
Okay.
clinically suspicious, I should say, for inflammatory breast cancer.
Mm.
But so I say that and make that point to say that you can't ever just disregard by somebody's age or what their symptoms are. These kind of things need to be worked up and followed up. If you're having anything abnormal go on with your breast,
Exactly.
then it definitely needs to be worked up. But we did, yeah. So we saw that, and it was really bad looking. So
That's why there's
And that,
guidelines, because surgeons have a low threshold to take a patient to surgery for that exact reason,
yes, right.
inflammatory breast cancer versus mastitis, whereas mastitis is treated very, supportively with warm compresses and primrose
Mhm.
oil and things like that, as opposed
Right.
to inflammatory breast cancer, which is a big, big deal,
Big
so.
deal. Yes, it is. So, just talking about those. So, but typically, these
Mhm,
benign conditions, if they're especially if they're proven and biopsy proven, if it comes to that, because a lot of times it does, you do need to biopsy things out and do needle biopsies and these kind of things, do
mhm,
cytology and different types of preliminary tests to confirm that it's a benign condition. But typically, we don't see these patients in the operating room
mhm,
across the board. So then we're going to move on to the malignancies. And I
mhm.
don't know that I'm covering all the major types of breast cancer here. I know I'm not, because I know you mentioned one that
Well,
we
we
didn't
can
talk
go
about.
we can go way down into a rabbit hole with that, which I
Oh,
think
we
it's
could.
for the surgical assistant. I mean, I think it's too much. I mean, we need to, yeah. So whether it's,
Well, and at some point it becomes redundant, not redundant,
yes.
but just kind of extra knowledge. What we
Hmm.
really need to know is the surgery that we're doing, and but
Hmm.
it's still interesting information
Oh,
to
for
know.
sure. I mean, you should, but I mean, it makes for a long podcast if we go into BRCA
Right.
negative and positive, HER2 negative and
Right. Oh, the
positive.
HER2 negative, I
Yeah.
know, all the hormone
Yep.
receptors and all this. And that is more on the oncologic side of things,
Hmm.
because what we do need to know, John, is that those are the types of things that determine what the course of treatment is going to be for the patient.
True.
So from that standpoint, it's important that we know. And I've never worked with a surgeon ever that I asked a question to, even as we're operating, like, what
Hmm.
is her course of treatment? What is her type of of breast cancer?
Hmm.
And they're more than happy to tell me and give me that information and really, invest in me and give me knowledge about it. So
Hmm.
if you're listening to this, I encourage you to ask questions of your surgeon. I mean, ask them questions. It's helpful. It's going to help you. It's going to augment your
Hmm.
knowledge, and it's good for us to know
Hmm.
that. But that kind of happens on the outside of the operating room after we take care of what we need to take care of
Hmm.
surgically. So just to kind of put in a little nutshell, I've got invasive ductal carcinoma.
Hmm.
There's DCIS, which is ductal carcinoma in situ. That's a very common one. That one is the one that tends to be more localized. Um, I wish I would have written this down because I don't want to
Hmm.
misspeak, but I think DCIS, ductal carcinoma in situ, is the one that is, it does not g- go to the other breast. Like, it stays unilateral. We'll double check that. You can edit that out if I'm wrong. I don't think I'm wrong, though. I think DCIS is the one that if you have it, it's typically unilateral, and it's not going to, that type of breast cancer is not going to go into the other breast. But we'll double check ourselves on that. Inflammatory breast cancer is one. This is the one that we need to know clinically. It's the infamous, is it peau d'orange, where the skin kind of looks like orange peel?
Peau d'orange. Yeah. That's
Orange.
yeah, I know. I'm not good
Yep,
at pronouncing French
I
names,
know.
but I remember that early in my career as a tech.
Yeah.
I remember a doctor was talking to a pathologist, and he said that her skin has that peau d'orange look, and I was like, "Ooh, what is that?" And so I
Have you
asked the
seen it?
question. Oh, once you
You've seen
see
it. I
it,
mean, I've seen it. Once you see it,
you know it, and it's
and
very
it does look
distinctive.
like an orange peel,
Yep,
yeah, and it's
exactly.
firm. It's generally firm.
Yep.
So inflammatory breast cancer is one of those that now they've come a long way in the treatment of this, a long
Mhm.
way, because used to, inflammatory breast cancer was pretty much, it wasn't a good, that was
No.
not a good, I
Right.
mean, it still isn't, but I personally know someone that has had inflammatory breast cancer,
Okay.
and she's 10 years out and doing great.
Yeah.
So, used to, that
It's
was
come a
not the
long way.
case.
Yep.
So just a little nugget there of how far these treatments have come, and I'm so thankful to work in a field where we get to literally see, improvements and evolution unfold in front of our eyes.
Mhm.
I've got ILC, invasive lobular carcinoma,
Mhm.
and then metastatic breast cancer could come from another primary site. And that's what I meant by metastatic breast cancer. It's
Okay.
a cancer that has metastasized from another primary site in the body. So let's move on no matter what kind of breast cancer we're treating, guys, we're gonna surgically treat them a couple of different ways. So, John, I'm gonna let you talk first about the lumpectomy and what that involves. I guess with or without the axillary node, the sentinel nodes and whatnot.
I mean, you mean lumpectomy versus mastectomy, or?
Yes. Well, we're going to talk about lumpectomy and why would we just be taking out, doing a lumpectomy versus a mastectomy?
Mhm. Well, before we get into that, let's go back and take a bigger overview, since we're going to get into breast surgery and talk about the origin of breast surgery. Just simple, quick overview, nothing deep or in depth. But I mean, breast cancer has been around as long as women have been around, and in
Mhm.
ancient times, like Greek, Roman surgeons and they did not know how to treat it. In fact, women would just die of that disease very easily. And it wasn't up until Halsted that there was a treatment for that. I mean, they would amputate the breast, and that was in locally advanced disease. They would just remove the breast before anesthesia, before Halsted. I mean, that was just a bad outcome and a bad morbid procedure for the patients with not a good survival rate. But it was Halsted that really moved the ball forward with his radical mastectomy. I believe it was, what was it, 1844, I think was when it was. Let me check my notes here. 1884, I'm sorry. So it was 1884 when Halsted described his radical mastectomy, and it was a hugely morbid procedure where they took the entire breast. So they started with like a teardrop incision that started right around the axilla, came around the whole breast, and then back to the start in the axilla. And they would remove the breast tissue, they would remove the pec major and minor muscles, as well as all the lymph tissue in the breast and surrounding areas and the axilla. And they would close as much as they could, but a lot of times they needed to have a skin graft because it left a huge defect. It was a very morbid
Mm,
procedure, a lot of complications. People suffered from lymphedema or other things, and it didn't
yeah.
always get the cancer. But as things progressed, there was a guy named Keynes that decided to try on really advanced cancer where women had no hope. He tried using radium needles that he had gotten from France, because we know Marie Curie, she discovered radium. So they had these radium needles, and they would insert them in these really bad breast cancer cases, and they noticed that the tumor melted away. So he started, hey, if it works on really advanced disease, let's try it on early stages of breast cancer and see what happens. So what he did was he would take these women, he would put the needles in and do a lumpectomy, leave the needles in, take them out about 7 to 10 days later. And they did just as good as the patients that had had the radical mastectomy by Halsted, but with not nearly the amount of complications. They had a better plastic result as well. So as things moved on, McWhorter in Scotland, they did a study where they were using just minimal techniques. And it wasn't until Cryle in the 70s, when Fisher had done some studies on breast cancer and how it migrated. See, what Halsted thought was it moved out centrifugally. So it started from the breast and then moved out to the tissue. But Fisher had done more in-depth studies with his brother, who was a pathologist. He was a surgeon, and they found out that cancer didn't actually spread that way, that the cancer was
Mm,
there before you could actually detect it by feeling it. By the time you felt it, it was almost too late at that point. But then Cryle came about in the 70s and started offering women a lumpectomy with x-ray treatment afterwards, or another type of therapy that didn't involve a radical mastectomy. And it was considered heresy. I mean, he was almost lost his medical license over it. He started writing books and articles. This was in the 70s about My Body, My Choice. And in fact, I think it was 1974, the then president, his wife had a radical mastectomy, and the vice president, Rockefeller, his wife had a radical mastectomy within 2 weeks of each other. And yeah, women weren't given really a choice. If you had breast cancer, you had a radical mastectomy. That was it. But in fact, in New York, yeah, I know at Memorial Sloan Kettering, if you went in the 70s for a breast biopsy, your consent read, if my breast biopsy comes back positive for breast cancer, I give my surgeon permission to remove any tissue he deems necessary. So it really got involved after that. I mean, they were doing super radical mastectomies where they were taking ribs and amputating arms because they didn't know any other way to treat that breast cancer, and they didn't want to leave tumors behind for it to spread.
mhm.
But Cryle started seeing results with just lumpectomy and treatment afterwards with either chemotherapy or radiotherapy, that, hey, these women are doing just as good,
Yeah.
and they don't have nearly the complications, and they have a much better quality of life at 10 years. So, and then those studies came out, like, I forget, what is the B30 study and the K11 study, where they randomized these people to one of two groups, and they showed that, hey, lumpectomy with sentinel lymph node biopsy and mastectomy are doing, these two groups are doing exactly the same at 10 years. So we don't need to do that radical mastectomy anymore. So surgery advances, but sometimes it advances slowly, which is good. And so now today we have the streamlined therapy that we have with, a lumpectomy and sentinel lymph node biopsy, or a mastectomy. So that's
Yeah.
kind of a brief history, a very
Yeah,
brief history
yeah.
of
Yeah,
breast
that's
cancer, breast
super
cancer
interesting,
surgery.
yeah.
Yeah.
Yeah, so a lumpectomy sometimes will be
Hmm.
called a partial mastectomy. Have you
True.
noticed that? That it'll be
Yes.
boarded or scheduled as a partial mastectomy, and it's really just a lumpectomy. So
Exactly.
this, in my mind, just means when that lump is, I should have looked up the diameter or the size parameters on that. I don't know if there is a specific size parameter that they're only going to do a lumpectomy. I know it does depend on the type of breast cancer it
Mm.
is, of course, what the pathology is that they're dealing with. Some women just want, they're like a therapeutic mastectomy. Like if it could be like a little ductal
Hmm.
carcinoma in situ, for instance, and she's going to say, just take my whole breast off. And I do think that insurance allows for that, for the woman to make that choice and to go ahead and cover it. She does want a mastectomy, a full mastectomy. But a
Yep.
lumpectomy typically is just taking out that lump of tissue surrounding the tumor. Of course, you'll see the surgeon take margins with this when he takes out a breast tumor.
Hmm.
Then we go back and take all the sides of margins to send off to pathology too, to make sure that the margins are clear. And so, there is such a thing as just taking the lump and not having to do check the lymph nodes. There are some cases where they're not worried about spread, or they
Hmm.
know that it hasn't spread. They know that it's localized only, or it's a small enough lesion. So that would, the lumpectomy would be, certainly that's the instances that we do see that only. When we start getting
Right.
into the lymph nodes and
Hmm.
whether we're doing sentinel node or axillary dissection, I think a lot of times you'll see these boarded as sentinel lymph node dissection, possible axillary dissection.
Hmm.
So, I think they have to board it like that for a reason. I think what you said is the truth, that obviously if we're not having to do a full axillary dissection, they're going to avoid that if possible, just for the reasons
Exactly.
that we've already talked about. I mean, there's a lot of anatomy there and landmines that we don't want to get into
Right.
and disturb. And I really appreciate that because have you ever seen bad lymphedema? You
Oh
mentioned that a
God,
second
yeah.
ago, when
It's bad.
such a bad thing to have to deal with. But back in the day, like you just reviewed, they didn't know any better. And they
Hmm.
just took all these lymph nodes, and it just interrupts that lymph drainage and really affects that extremity. So,
Yes. So when it comes to lumpectomies, you have to obviously localize the tumor. So there's several ways that, you can localize the tumor.
mhm,
You can put a little RF chip in there, or you can use a wire localization. For the longest time it was a needle loc. I mean, you would see it booked
mhm,
as breast biopsy with needle localization,
mhm,
possible, whatever. So they still do that, although most places are getting away from wire localizations for lots of reasons. It's technically challenging and it ties up the patient in X-ray, especially if they can't exactly localize it. So, but a lot of times they'll do that. There's seeds that they can put in there, and there's other ways of finding it. So, like a lot of times, but we'll probably get into that when we talk about, all the stuff you need to have and make sure you have ready
yeah,
for,
no, that's perfect. Yeah, no,
for,
it's
for,
perfectly good to talk about that. I mean, I'm glad you brought it up. But that one
mhm.
of the common things now too is that Savvy Scout clip, that Savvy
Yes.
clip
Hmm.
that they will do. A lot of times, not a lot of times, they will schedule that on the morning of the surgery.
Hmm.
The patient comes into X-ray or IR, they do it, and just, use X-ray or ultrasound guidance
Hmm.
to put that clip in the tumor. And then we have our equipment in the operating room that helps us locate that. So all those things really have made it just so, I love that Savvy Scout. It
Yes.
helps you, it tells you how many millimeters under the
Hmm.
skin that the the depth there that you're dealing with. So
And
really
granted,
cool, cool
this
things.
podcast is hopefully people who are surgical assistants all over the country would listen to it. And the way they do things in different parts of the country, surgery is regional just as much as anything else.
It
I mean,
is.
I've been places where they still just do needle lokes, and now some places are
Mhm.
using the mag seed or, other
I've
things.
never
So
I've
there's,
never seen a mag seed, so I'm
yeah.
not familiar with that. Needle loke I am, but
Hmm.
honestly, in my local facility where I'm working as staff currently, I don't we rarely see needle lokes anymore. It's Savvy Scout all the way, the clip. So
Exactly. Well, the hospital I was at previous to here, they still did needle lokes, but they would also put a clip in there as well. But
Mhm.
it was basically just a metal clip that would show up on X-ray. So when you use the Faxitron or the Hologic Trident,
It shows
you
up.
would see it, right? So you know that you got the area you were looking for. Now, Hologic has a lot of things that are specific to the breast. They, I believe they do run the Trident, which is that little Faxitron or that little mini X-ray machine. They also have True Node. I think they just bought that company, which is a
Mhm.
disposable radioisotope gamma camera. Um,
Mhm.
but yeah, I think there's many ways to localize it. And the mag seed is a little like not radioactive, excuse me. It's magnetic. So they can put that in well in advance of the surgery. It could be done the day of surgery, or they can do it a week ahead of time. So it doesn't really matter.
Okay. All
And then
right.
you detect that with a little wand that you drape out aseptically. You put a drape over it, you bring it up to the field, but you have to have all the metal instruments away from the
Mm.
operating field when you do that, because it will pick up the metal in the IO stand. You
Oh,
can't have a
because of the
Mayo stand.
magnetic
Right.
component.
Can't have
Mhm.
like a hemostat on the patient that's
Huh.
too close to this, because it will what they give it what they call drift. So a lot of times there comes with a foot pedal, so you want to make sure that obviously this is opposite the surgeon, because they want to look at it opposite the affected side so they can look at it. And you want to make sure that the foot pedal is accessible to them, because the foot pedal is what zeroes it. So you have to constantly zero this thing.
Mm.
And they have
Okay.
plastic instruments that you use, plastic retractors, plastic pickups, because you don't want the ferrous component of the stainless steel to interfere with this. But it's a great way to localize it, and it gives you a
Huh.
count similar to what the neoprobe does. But
Mhm.
you can use it to detect the mag seed, or they have what's something called mag trace, which is it's an iron oxide that you inject peri-areolary like you would for methylene blue or lymphozyme or
Mhm.
whatever, and that's to help localize the sentinel lymph node. But the
Right.
nice thing about that is it hangs around 2 weeks as opposed to 6 hours for technetium. But we're getting far
Yeah.
ahead of where I am, but
Yeah. No, I do want to differentiate though that we're kind of intermingling the two, that we're talking about localizing the lump, the
mhm,
actual lump of tissue or tumor that we're taking out. We're kind of
mhm,
intermingling that with the lymph nodes, dealing with the lymph nodes. So I do want
right,
to take a moment to differentiate. We're talking about marking the tumor for the lumpectomy, but then we do
mhm,
also get into when you're looking at a sentinel node, and we know that the sentinel node is the first node that is drained by the breast. So all the sentinel node is means the first node that's gonna take up that drainage from the
mhm.
breast, right? And so they want
And
to
cancer
locate
cells.
it
Mhm,
and test it. So the the methylene blue, and the technetium 99 is
mhm.
what's going to help us to locate the lymph nodes
Correct.
versus the lump. So I just want to differentiate that. We were kind of and naturally we just kind of got to talking about both of those and some
Mhm,
equipment that we might need and have in the room. But the lymph node, as we know, so you're going to identify that with the blue. Some I've seen them just use the blue dye. Now, when they
mhm,
use the blue dye, we do want to have that drawn up. A lot of times, and your surgeon's going to tell you, but a lot of times I have it drawn up on little prep stand, pair of gloves, some 4x4s,
mhm,
have it drawn up in the syringe. And after the patient's asleep, before we prep, the surgeon will come in, inject it right into the areolar region, and then kind of massage it with a 4x4. The breast can start draining that down, so that then when we finally get into that axilla, we're going to be able to see the blue. You're going to be able to visualize the blue dye. Now, and some doctors will do it on the sterile. Wait till we're prepped and draped and do it sterilely. You can do it both ways. The other way is the technetium. So that's going to be the neoprobe or the true node, whatever
mhm,
device your facility uses, is going to pick that up with the. And John's right. You do want to think about when you're thinking about these cases and setting them up. You want to think about putting those readings where he needs to look at a screen and read the feedback that it's giving him on the opposite side of the affected breast.
Mhm.
So we're operating on the left breast. We want to put those things on the right side of the patient
Mhm.
and vice versa. So the surgeon. So these are just some little things to think about as you're setting up the room. But yeah, so those are all, I think most of us have seen those things. There's probably, like you just
Mhm.
mentioned, one or two things, the mags, the magnetic.
Yeah, the mag seat is
I've
crazed.
never seen
Yeah.
that. So, you know,
Mhm.
again, if you know of something that you know about that's
Mhm.
new, and please comment and let us know.
Well, the reason I brought up the Centimag is the name of the system. The reason is because it has that dual purpose. You can also use
Mhm.
the mag trace instead of using a radioisotope to find the sentinel lymph node. So
Mhm.
what's nice
Yep.
is if you use that, it hangs around for 2 weeks. So if you have to bring the patient back, you can localize this. Like let's say that, their biopsy comes back positive and you need to do a sentinel lymph node biopsy. Well, you don't have to give
Right.
them a dose of a radioisotope. You can use that mag seed and it'll hang around for, 2 weeks. So
Yeah.
if at the
Yeah.
time of
That's
surgery they don't
interesting.
need a sentinel lymph node biopsy, but they need it later, that stuff hangs around for 2 weeks. So it gives you, if you get the pathology back fast enough. But
Yeah.
um,
John mentioned too
mhm,
the X-ray, the Trident machine, and some
mhm.
other machines, because otherwise you have to send, once you get
Some
that lump out
places,
with
yep.
the clip in it. At our facility, we don't have the Trident. We don't have anything
Oh,
to
you
bring
don't.
into the operating room to X-ray the breast. So a runner's got to come pick up the specimen,
Mhm.
literally go out of the hospital, go across the street to where the
Oh,
X-ray
wow.
department is, and have that specimen X-rayed so that we can verify. And then the radiologist has to call the operating room. So it's a whole big thing. That's a lot. But if your facility has a Trident or one of the other machines that you can X-ray that specimen right there, let the surgeon look at that image and make sure that that's encompassed, that the clip that was marking the tumor is encompassed in the specimen.
Mhm.
That's what they're looking for. They always will do that confirmation before closing up the patient. Anything else we're talking about there? We're gonna
Well,
move on. We can talk about mastectomies, and then we'll go into wrap it up with some of our positioning and kind of recap our equipment and whatnot that we might need.
okay.
So really, mastectomy, I mean, it's pretty straightforward. We're not doing very many radicals these days.
Very rarely. I mean, I
I
haven't
mean,
seen a
that's
radical mastectomy. It's always a modified radical. I've never seen, they
mhm,
don't do radicals anymore, at least the way Halstead
anymore.
described it, they don't do them just because
Right.
it's such a morbid procedure and it's not warranted.
Right. So we talked about a partial mastectomy is
Mhm.
just what it says. I mean, it's typically a lumpectomy. Simple mastectomy is when we're taking that entire breast off down to the chest wall. So all the breast
Mhm.
tissue down to the chest wall. You'll see your surgeon mark that out on the breast and make sure that it's going to close, that he's taken enough tissue, but that it's going to close appropriately. Even if it's not a skin sparing, and we'll talk about that, coming up. We're going to get more into the skin sparing mastectomies when we're talking
Mhm.
about reconstruction and getting that skin ready for expanders and implants. But we're talking about a simple mastectomy. We do want to make sure, that's something we want to make sure of, that skin that we're leaving behind is going to close appropriately. And then the radical includes the axillary tail, the chest wall muscles, and all axillary nodes. And like John said, that's rarely done, if ever,
Mhm.
now. So typically the modified radical. We're going to leave the inferior muscles, but it excises the fascia and only some lymph nodes.
Mhm.
Would that be accurate, John?
Mm,
Yeah.
yes.
Modified radical.
Mhm. And the
All right.
incisions
And
for
then,
mastectomies are, it's patient specific too, depending on the size of the women. You have elliptical incisions.
mm-hmm,
Then you have enlarged breasted women, you can use radial or superior pole oncoplastic incision, which will kind of incorporate some of the nipple.
mm-hmm.
Smaller breasted women, you could use a modified Wise incision. It just depends. So there's several different types of incisions that are used for mastectomies, although we tend to just see the major ones, which are the Wise, and I'm blanking on the other one right now. But yeah, so that's
I see the
mastectomy. So
elliptical. I mean, I see elliptical seems to be very common in
exactly.
what I'm used to, especially if we're working with general surgeons. So we all know
Hmm.
general surgeons can specialize and certainly obviously operate on the breast, but I see that there is sometimes a difference in how those incisions are approached in our surgical approach, whether you're working with a general surgeon who does a lot of breasts or a breast surgeon or a plastic
True.
surgeon. So we have all these different types of surgeons. different training to consider. So just know who you're working with
Mhm.
and know what they like and what they do on the routine. That's an important point. Yeah, to wrap it up, we're going to talk about the equipment. We've already mentioned some of the potential equipment and positioning. So what are some positioning pearls that we need to consider, John?
Well, it's obviously surgeon specific, but depending on if we're doing an axillary lymph node biopsy or dissection, I like to bump up that side. If the patient usually likes to have the patient bumped up, moved, when we position the patient, move them as close to the edge of the table as possible on the affected side.
Definitely.
You want to make sure that the arm is not abducted too far because you don't want to give them, any kind of brachial plexus injury.
No stretch, right? Mhm.
Exactly. And then typically, when I do breast surgery, depending on the case, I always want to make sure that everything's in the room and ready the way the surgeon likes it. So obviously, that's reviewing the preference card. It depends on the facility. The facility I'm at currently, I can't draw up the lymphozurin or the methylene blue, whichever they use. Most surgeons use 2 cc's and 1 cc of either methylene blue or lymphozurin, 2 cc's of saline, or the opposite. It just depends on what cocktail they like. But I like to have that in a little e-basin drawn up because the nurse will draw it up. I usually like to keep the vial right there, or at least I write down the
Mhm.
lot number of whatever is the methylene blue or lymphozurin that they use. And that's surgeon specific as well. A lot of surgeons will use
Yeah.
lymphozurin because that's the way they were trained, but some surgeons get away from that because they've seen anaphylactic reactions with lymphozurin, which is isosulfan blue. But some patients
Uh-huh.
can have an allergic reaction to it, so they'll just use methylene blue. So I usually put that syringe in an e-basin with a couple of, well, actually with a bunch of 4x4s and
Mm.
prep pads and
Yeah.
a pair of unsterile gloves.
Yeah.
And a lot of times they'll
Mm.
prep pads and a
Yeah.
pair of unsterile gloves,
Yeah.
and then they'll massage it for 5 minutes. Some surgeons are really, really specific about massaging it for 5 minutes. Some don't.
Mhm.
Some just
That's
inject
true.
it, massage it for a couple of seconds, and then walk away
Mhm.
because you
Mhm.
need to give it time to diffuse out into the lymph system. And so then I'll make sure that the Trident is in the room if they use it and it's warranted. I'll make sure that there's an X-ray view box in there. Some places have a portable X-ray view box, and then the ultrasound machine and the neoprobe or
Mhm.
True Node or whatever,
Whatever
Centimag
it
or
is,
whatever they're
yeah.
using. And I'll make sure that that stuff is all positioned opposite the affected side. So while the surgeon's operating, they can look and see it directly across.
Mm.
Usually the ultrasound they'll get rid of right away once they identify and localize the lesion in the breast, if the case requires a breast biopsy and sentinel lymph node biopsy. But some patients have a clip inserted in the breast tumor and in the sentinel lymph node if it's identified ahead of time. And so I've worked with surgeons that like to do that. They like to visualize preoperatively. They'll take the ultrasound, find the clip. Some will inject it with methylene blue, and some will do the same with the axillary lymph node. If it's been clipped ahead of time, then they'll inject a little methylene blue around it, further help identify it. That's where the benefit of both using the dye and the radioisotope comes into play, because a lot of times you can actually, it's cool when you get down there and you incise the fascia and you can see the little green or
Mhm.
blue line of
Yeah.
that
You can see
that
the
dye going right to the lymph node.
yeah.
And I always make sure that whatever, some doctors like to use the ligature, some like to use the harmonic scalpel, but you want to make sure
Yeah.
that most doctors use some sort of sealing technology so they don't get any lymph leakage. Now, that being
Mhm.
said, I have worked with a surgeon in the past that shall remain nameless at the facility that shall remain nameless that used to just avulse the lymph node. This person
Hmm.
would identify the lymph node, and the first time I saw it, it really shocked the hell out of me because they just literally grabbed the lymph node and jerked it, like yanked it out. I was like, oh my God. It was
I've never seen
really,
that.
I've never seen that
Hmm.
anywhere else either. And I've asked other surgeons about it since then, and they just don't advocate that technique. But like I said,
Oh,
I don't know everything in
it
surgery. And obviously,
right.
this is a breast trained surgeon. So they've done, extensive training for breast surgery beyond that. So I'm not going to say that's
Mhm.
right or wrong, but it's the only place I've seen it
Mhm.
done, the only person I've ever seen do it. So yeah, I'll make sure
Mhm.
that that stuff is all in the room. I'll make sure they have the harmonic scalpel and that the Trident machine is in there and hooked up, and because that all that patient information needs to be in there. But that's the nice
Right.
thing about the new Trident machine, is that all those patients for the day will be in there, and it's easy to find the patient. The newer Trident is much easier to use than the old Faxitron machine.
Right.
So that's
I
typically
will
what I'll
say
do, and then I'll
at my
also.
facility,
Mhm.
I what I did, John, is I got a breast cart together for the surgeons at my
Mm.
facility, so they're gonna
Okay.
all use they like the plasma blade. So on this
Oh,
breast
okay.
cart, it's a tall, narrow cart, and I've put the plasma blade, We have 2 true nodes, and, if you're familiar with the true node or if you're not,
Mhm.
it's the system because we used to use the neoprobe, but the true node is the one that's got the lapped like the iPad thing that
Mhm.
I just, twist it onto the IV pole, and we use the disposable sterile probes. So we have 2 of
Okay.
those, but I put a breast cart together
Oh,
that's got
nice.
the true nodes on there, the Savvy Scout, and the plasma blade. And so
Okay.
that you can just take that one thing and wheel it into the room, and you've got all those things. And if there's another breast case going on, we can at least take the true node off. And there's a second true node, in other words, that we
Mm.
can split with the other room. They do try to do good about not scheduling those to conflict. But
Mhm.
that's one thing I've done. But the I do wanna drive home that the reason we're talking about this, guys, and even back to the methylene blue and how you set up in the E-basin, that's a good way. Like I mentioned, I do it on the prep stand. Anticipate, anticipate, anticipate. Okay, this is just
Mhm.
going to up your level. You're gonna be above average. You're not gonna be the first assistant that's walking around the hallways, just waiting to come in with the surgeon. You wanna be
Mhm.
proactive in your room. Make sure that you have lined up what you need. If you have that Trident machine, like John said, have it in the room. You know, give your ORAs a heads up. At my facility, I might say, hey guys, we've got a breast case coming up. We're going to need a runner here in a little bit when we get the specimen out. Just
Mhm.
be all ears for that. Just kind of really being proactive. We want to elevate ourselves, right? And just have that level of professionalism and put yourself above average. And having all those things lined up makes the case go so much easier. You're
Mhm.
helping your circulator, you're helping your CST, you're kind of the glue that's bringing everything together. And I just want to encourage you that it makes a big difference when you've got everything lined up and the surgeon doesn't have to say a thing. Back to
Mhm.
your bump, you said you bumped up that side. Kind of, we're talking about the operative side
Mhm.
and putting a bump under the chest wall. Some surgeons don't
Mhm.
like that. I've worked with surgeons that want it 100% of the time.
Yep.
I work with surgeons that make it patient specific. So you want to know the size of your patient, know what kind of habitus you're dealing with. Are you dealing with a fluffy patient with lots of, fat
Mhm.
rolls, a big breast, a small breast, a little thin older woman? Who are you dealing with? So all these considerations that were so typically they're going to be supine. I like putting a pillow under their knees to
Mhm.
support their lower back for the case. You're going to have that lower body
Yep.
bear hugger.
Mhm.
Check with your circulator. Do they want everything streamlined to the foot of the bed as far as all the equipment goes? So just some considerations to think about, as you're setting up this room. One thing I did want to bring up, John, and I talked
Mhm.
to you about it on the mastectomy closures, the Prenio works really well for this. So if you can do a stratafix in that skin, closing that skin, interrupteds, we try to do deep dermal interrupteds with a Vicryl or a monocryl 3.0 in the deep dermis. These closures take a while on a mastectomy because this is
Mhm.
not a little tiny incision, right? If you can use a 4.0 monocryl in the skin or a Stratafix of some sort in the skin and then put that Prenio over it. I've just been working with a surgeon recently that just started using the Prenio probably 6 months ago or so, and he loves it and has gotten really good results out of it. So obviously that's not a decision you're going to make as the first assistant on your own, but just a little, tip from me that I've liked Prenio on total knees also in ortho
Mhm.
and seen good results with it and known several surgeons that I've worked with that really like that. So that's something to consider there. Typically, you're then going to do fluffs and a bra over again, surgeon specific, what they want to do. Do you have any other thoughts there?
Yeah, when it comes to positioning, obviously, I like, yeah, definitely a pillow under the knees, the bear hugger, a bump under
Mhm.
the affected side, and I worked with a surgeon that also likes a bump under the arm too, so they're both at the same level. Even if it was a bilateral breast biopsy with sentinel lymph node biopsies on bilaterally, she wants both sides bumped and both arms bumped, even though that way it elevates the patient off the bed, so you have
Correct.
more
Yep.
degrees of motion that you can do. And then I usually use 2 straps on each arm, or I wrap the arm with Curlex. Some doctors like the arms wrapped with
Good
Curlex.
point. Yep.
And then when
Mhm.
it comes to draping, a lot of breast-specific surgeons will use the universal pack that comes with those 4 sticky drapes. Some will just use a regular lap T sheet that you cut. One thing
Mhm.
I found that helps, that I like, because I don't like gaps in the drapes and seeing the blankets underneath, is using leggings over each arm for a
Yes.
mastectomy, and then covering
Mhm.
that with another sheet and stapling it together. I use a lot of, stapling, like surgeons like to staple the towels, they like to staple the drapes, so that helps a
Mhm.
lot. And then I worked with one surgeon that was very specific about her draping, and I did minimal assisting in draping because she liked it all. She had a specific routine and she did it the same way every time, which is nice. So I just got back out of the way and let her do that, and then came in. And then, true, when it comes to closing mastectomies, they do take a while depending on how big the breast is in the incision, and usually it's a lot of deep dermal, buried deep dermal
Mhm.
interrupted,
Yeah.
and then a running subcuticular. And in fact, that one
Mhm.
surgeon that was very particular about her draping, depending on the surgery, usually when it was a mastectomy, once we got to the closure part, she'd put a few in, and then she would ask another surgical assistant to come in so we could both close it together, making it,
Mhm.
obviously faster
Right.
rather than one
Right.
person doing it.
Yeah.
So, and that's where you collaborate with your surgeon. Some places, like the place I am now, I have more autonomy on my closures and what I can use for closures and
Mhm.
dressings, or
Mhm.
some surgeons are very specific. So,
Yeah.
I'm going to start asking that surgeon I work with now if he wants to try pernio on his mastectomies, because I
Mhm.
think that will help a lot. But
Mhm.
it depends on if he's open to it. I mean, I could only suggest it, but you know.
Sure, but I know one of the main surgeons I work with now has just been so happy
Mhm.
with the results he's seen in the office, and unfortunately for us, we don't get to see that side of it. I love to be
Right.
able to see the patients afterward, and I've been fortunate enough to work in that environment where I've been in the office and the operating room, but I'm not currently in that role. One thing I do want to mention that we didn't is sometimes if you're a newer first assistant or if you're at a new facility, if you're traveling or you've just started a job, check with the surgeon. If they Some surgeons will want to prep in the entire arm. They want to prep the whole arm, the
Mhm.
hand, put a stockinette over the hand, and have that entire arm draped in. Now, I have seen this more when they were anticipating doing a full axillary dissection and they wanted to have that movement of the arm,
Mhm.
especially in larger patients. I have seen that go by the wayside though here lately. I don't know if it's just the surgeon specifically that I'm working with, but
Mhm.
we rarely prep the entire arm in now. I do love the idea of putting that legging or even a Mayo stand cover over that unprepped arm works as well to kind of keep
Mhm.
that underneath sterile, and then we don't have those gaps. So that's a good tidbit also. But gosh, I think we just about covered it, and we're going to be going into part 2 of this. We're going to go
Mhm.
into reconstruction, I think is what our plan is, but hopefully we've given a lot of good information to people.
Yeah, I think just the big things to remember are whatever your specific equipment you're using to localize, whether it's the breast biopsy or the sentinel lymph node. One thing I forgot to mention was the fluorescent tracers. I hear that's being used. Well, I have not seen that, but I know some institutions are using indocyanine green. And I guess it's all dependent on your institution, because the True Note is nice and those disposable gamma cameras are nice. And basically, if we haven't talked about it, how the technetium 99 works is it's a radioisotope that's injected either into the tumor or subareolar, just like the methylene blue or lymphozurin is. And then it travels to the sentinel lymph node and some of the other lymph nodes as well, but it gives off gamma rays, which is what the probe is picking up. It's picking up gamma radiation, which is not as harmful as other types of radiation because it's so small, the wavelength that passes right through you. And, a lot of times it doesn't hit anything to cause any damage. And it's got a very short half life of 6 hours. So it's excreted through the kidneys and gone pretty quickly out of the patient. So, but some places do use the mag seed or mag trace for that, or some places are now using the indocyanine green, which I haven't seen. But the True Node,
Mhm.
like I said, has the disposable detectors, but that is a cost. That's a disposable consumable cost that the patient has to pay for. Whereas when they buy the neoprobe system, the only charge is the technetium 99, which in and of itself is very expensive because it has to be made in a nuclear reactor. Molybdenum is the parent isotope for that, and that has to be exposed to neutrons in a reactor in order to turn into technetium 99,
Mm.
and that's only good for a certain amount of time. So it depends on how the way the hospital does it, but there's a significant cost involved in that. So some hospitals are getting away from that. So they have to weigh the cost of technetium 99 versus the True Node. And I'm sure the True Note is much less expensive than the Technetium 99. So, there's several ways to do that. But just having all the equipment and everything that you need and reading the H&P ahead of time to make sure you're up on the patient's condition. Just as a point of when I was doing a case, I was working with a surgeon last week, and we were doing breast surgery all day. And I read the H&P on the first case, and it said that the lesion was in the 12 o'clock position on the breast. And he comes in, he gets the ultrasound, and he's looking at the 6 o'clock position. And I also read the H&P for the next case, and that patient's lesion was in the 6 o'clock position. So he was looking, and he's like, I can't find this clip. And I was like, have you checked 12 o'clock? Because I believe this patient's, and I said this very low, close to him. I
Yes,
was
of
like, when I
course,
read
you're
the H&P,
tactful.
I could have sworn I read it was at 12 o'clock. But he has the nurse,
Mhm.
and now we're already sterile at this point. So he has the nurse pull up his H&P, and he reads it, and he was like, oh, yeah, it's at the 12 o'clock position. I must have read the next
Mhm.
patient. And then he said that
Mhm.
during the next patient, he's like, oh, yeah, I was thinking about this patient at 6 o'clock because I
Mhm.
must have read her just before I came in. So that's why I like to know, for just that, help streamline the
Yeah,
surgery, but I don't
absolutely.
do it in a
Mhm.
big way. Hey, doc, you're in the
No.
wrong place, man.
No,
I
we
just say
always
it
use tact, but
quietly. Exactly. Say it quietly to
that's a good
him,
point
because I don't want
that
to, I don't even want
you
him to
just do
take.
that little bit of homework. Mhm.
Exactly. It
Yep,
just makes for better patient care. You can
it
streamline it.
does.
So instead of spending
It
20
does.
minutes looking for something, you're like, oh, let's try here. And
You've got
then it's
information
easy
that
to
he needs.
find.
Yeah.
Exactly. And
Yeah.
sometimes those things aren't easy to find, even when you know where they are, because the patient's got a big
Right.
pendulous breast or they're very
Mm,
fat. So,
right, right.
but, knowing
That's
your
true.
patient, knowing the H&P, and making sure you have all the equipment necessary.
Mhm. Mhm.
So,
Well, good. All right. Well, this has been fun talking about the breast and the surgery and all the things. And we're going to, yeah, delve off into a couple more parts. So just keep your eyes open for that. We'll have part 2 and 3 of the breast. We anticipate it's going to take 2 more episodes to finish
mhm,
talking about all of the things that we deal with breasts.
mhm,
So we appreciate you listening today and hope that you're enjoying. Please drop us comments. Any kind of feedback you want to give us, we're open to it, and
mhm.
suggestions or whatever you want to say to us. And
Yes, thank you very much. And thanks for joining us on this episode. And we look forward to seeing you on the next episode.
yeah,
And please remember to like, comment, and subscribe. So, the Surgical Assistant podcast does not offer or give any medical advice, nor do we give out any HIPAA specific information. This is not meant to treat or diagnose any illness. It's simply meant as information for surgical assistants. So, thank you for joining us. If you'd like to contact us, you can email us at the surgical assistant podcast at gmail.com, or look for our Facebook page.
yep. All
So,
right. Have a good one,
see you
everybody.
on the next one. Thank you for joining us today. We invite you to like, comment, and subscribe to our podcast. Feel free to look us up on Facebook at the Surgical Assistant Podcast. If you like, you can also email us at thesurgicalassistantpodcast@gmail.com. We look forward to seeing you on the next episode. Content of this podcast is created for surgical assistants and is educational only. It is not intended to diagnose, treat, or offer medical advice on surgical conditions. No patient-specific information is shared, and all HIPAA guidelines will be adhered to.